Good morning, everybody. I will say a few words. I would like to welcome Professor Yamagishi and Dr. Tousy for being with us today. We also will have Dr. Amir on fungi infections after Professor Yamagishi. And I think it's a very, very important event. I first heard Professor Yamagishi in the discussion held by the Ministerial Asia Pacific group on AMR. And it's a very, very important group that is there, that includes Malaysia, that includes the Australia, that includes Japan, of course, and other countries. And it is my hope that Professor Yamagishi, who was kind enough to talk to us about how to do AMR outbreak investigation, will also kindly come to Dubai and come to South Africa and travel to countries to explain to health structures how to do these, because it's so important. I'll just say one last comment. I used to live in France, and as recently as 3 years ago, the European Centers for Disease Control said that actually nearly the majority of AMR infections were contracted in healthcare systems. So we need to have, as an absolute priority, a good way to investigate outbreak infections of AMR, because if we don't have that, we're not going anywhere, and new drugs will not solve the problem, nor will being sure that patients, quote unquote, behave. We need to have a very strict structural way to do things well and do things with a no blame attitude. It means doing investigations without any fear, without provoking any fear on the part of healthcare workers that they could get fired as a result of having made a mistake and having been at the origin of an outbreak investigation. The no blame attitude was initiated by Sir Lam Donaldson when he initiated the program on patient safety with the WHO, the UK funded the WHO. And at the time, I joined the Patient for Patient Safety because Sir Liam insisted that patients had to be involved. I had polio, very severe, from a vaccine, one of the first clinical trial on the market in which the virus was not inactivated. So I have the experience of having suffered a major mistake in healthcare. And in my life, I've also worked on strengthening infection prevention and control against HIV and tuberculosis in French-speaking African countries. That stated, I'm very happy with this webinar. And I'll let Dr. Tousy say a few things. Dr. Tousy is an eminent specialist in emergency medicine in the UAE and also in other countries, as he can tell you. Thank you.
Thank you, Gareth. Very kind of you. Yeah, I think we're just waiting for Prof. Yamagishi. He was on a few minutes ago, but I think I can't see his screen. So we're just waiting for that, but I will add a few words. Thank you, Gareth, for and the team, I must say, for the really hard work that's been put in organizing this seminar or webinar. And originally, if you guys know, the idea was to have a live conference. The time scale was a bit short, so we decided to start with webinars, and we have three. One today. This is the first session, first webinar of the three, and then later on this afternoon there's a second one, and on the 20th morning Dubai time is a third one on different topics. So they're all similar. This one is on AMR investigation. I'm just waiting for, I'm talking a little bit on and on because I'm waiting for Prof's screen to appear. Because as soon as it does, I'll hand over to him. But Professor Yamagishi is an eminent researcher in this field. He's a researcher in emerging infectious diseases, event-based surveillance, healthcare-associated infections, antimicrobial resistance in Japan. But he's also investigated many outbreaks, including H1N1, severe fever with thrombocytopenia syndrome, and also carbapenem-resistant enterobacteria in Ebola virus disease, Zika fever. So he's got a lot of experience with this field. And we know how difficult it is to, investigate. There's always a political overtone, which makes it a challenge. So, we're waiting to learn from his great experience. I mean, he's a facilitator of the field epidemiology training program. So this is a program that he facilitates, and so he's got a lot of experience teaching and educating professionals all over the world in this field. It's not directly my field, but I'm interested in antimicrobial stewardship and resistance throughout my career. In particular, when I was at Sheikh Khalifa General Hospital, we instituted in the emergency department UTI, sort of audit, in which we were looking at what antibiotics were given, and then following up patients' culture results and seeing if those antibiotics were the right antibiotics, or whether there was resistance to those antibiotics, because we're a big advocate that resistance patterns, the antibiotic prescription, should be a local phenomena, should be led by local resistance patterns. I mean, it's fine to look at recommendations from the US or abroad, or Europe or UK, Australia, but that may not reflect what's happening on the ground, particularly in the UAE, and particularly also in low-income countries where there may be different patterns. So it's really important to be local with this, and have knowledge and have experience and have data locally. As Edward Deming, the sort of the father of quality projects, said, and he, ironically or interestingly, he was actually involved with quality improvement for industrial processes in Japan after World War II. So he's credited for being, an advocate of that, or a big change advocate of that program. As he said, you can't make change without data. You need the data to know what's going on, and sometimes we lack that, and it's something I would advocate. So I'm just waiting. Is Professor Yamagishi later on this afternoon? While I'm still waiting, we're going to have Dr. Afrinesh Amir from Pakistan, who's project director of the Antimicrobial Resistance and National Fungal Disease Surveillance Program at the National Institute of Health, Pakistan. She'll join in a little bit. So she's got another meeting just before. So as I said, this is a bit of a test. We have a new platform, and this is a new team, and we're working really hard to put together a series of events focusing on antimicrobial resistance, on waterborne infection, airborne infection, and also wastewater treatment and surveillance. And also bloodborne. So, all of these are really, really key topics for really all physicians, all healthcare workers, all people, because as we know, hepatitis B, C, HIV have been big problems. This continue to be big problems in certain parts of the world, and what we need to do really is learn from, and some countries have done a good job of controlling these, but we need to learn from them, but also how do we support each other and use international organizations like WHO to help stem the tide of these. So that comes later on, how airborne transmission happens. We've all lived through COVID-19 and have clear memories of that, and we know that the quarantines and curfews that happened. Oh, there we are. I think we can hear him. So with all of those, I think what happened was we don't know what actually worked and what didn't, but it causes a huge disruption to all our life. And we need to later on in the program, we will see what works and what may need to be done better than we did before. So, Professor, we'll kick off with you if you don't mind.
Good morning, everyone. My name is Takuya Yamagishi, as the Dr. Tousy introduced, and I'll skip my introduction slide. So today I'd like to talk about the risk assessment and the outbreak investigation of the AMR event. And here you can see my 3 contents. What is the risk assessment for acute public health event as a whole? And I'd like to move on to the next part, how to assess the risk of an AMR outbreak in healthcare settings. As Dr. Garens mentioned that the AMR outbreaks occur in healthcare settings mainly, and also the ICU is a hot place for the AMR outbreaks. And third one is about the investigation of an AMR outbreak in healthcare settings. So there are tons of outbreaks of antimicrobial bacteria in healthcare settings. You can find out many outbreak reports in PubMed. And the contents of these outbreak reports are just a tip of the iceberg. And there are many stories behind these reports. And there are many learning points in these background scenarios, stories. And one of the interesting and important learning points, and probably the most difficult one, is when and how to trigger the outbreak response. And this is the risk assessment of the AMR outbreak. And first, you need to confirm an AMR outbreak. Usually, you can detect the outbreak through routine surveillance. And many of the audience in this webinar have the experience of doing looking some surveillance data. Many countries have the surveillance for carbapenem-resistant Enterobacterales and MRSA, methicillin-resistant Staphylococcus aureus. And some countries have the surveillance for vancomycin-resistant Enterococcus faecium, or etc. And some specific pathogens, even a single case can be an outbreak, such as the vancomycin-resistant Staphylococcus aureus or ceftriaxone-resistant Neisseria gonorrhea. And in Japan, we have several indicator-based surveillance, such as this is a routine surveillance. One is the NACID, Chinese. We can skip this one. And through the surveillance, if you can find out the one outbreak, it is good. It is you're happy. However, you may use other information sources. But before going to the EBS, I need to just quickly introduce the important interpretation points in this slide. Before interpreting data, it is important. It's better to talk to the microbiologist or microbiology team before concluding the findings, before deciding that this is an outbreak. And the new important part is the new methodologies, how to interpret, and the whether these findings is usual or not. And sometimes it's within the baseline. So you need to ask the microbiologist. And also some irregular ad hoc type information can be trigger for the outbreak response. And if these reports you can find out, then you can mention that this might be caused through the event-based surveillance. The event-based surveillance, EBS, is the organized and rapid capture of information about events that are potential risk to public health. And the information can be a rumor or some ad hoc reports or some talking about the confirmation of AMR outbreak. And to detect the AMR outbreak, you need to utilize the routine surveillance that is called indicator-based surveillance. And also you can utilize the information, informal information, such as sometimes it is called event-based surveillance. So this is a kind of rumor or the informal information from the local doctors, a phone call from the doctors or something like this. And this is just a schema to outbreak replication or confirmation. So through multiple sources of information, IDS, EBS, you can find that, or you can detect the event. And sometimes it's the fourth should outbreak. So you need to check whether the diagnosis is correct, or you need to check the clinical and laboratory data, and you need to also check the link between cases, and you also need to check whether this is over the normal baselines. And after excluding these possibilities, you can verify or confirm the outbreak. So after confirmation of an AMR outbreak, what to do next? Is it worth spending your time to strengthen control measures, including further investigation? Or you can just relax and leave it. This is a very important point. And you may have tons of outbreaks, but among them, some need to be urgent responses. Some you need to do right now, but the most of the events you just relax. You can just relax. So this is a risk assessment. So the aim of risk assessment is to determine the need for and type of escalation response that may be required. The response that need to be escalated is, for example, setting up an outbreak management team. So I'd like to move on to how to assess the risk of an AMR event. And even though there's some overlap, we think that you need to check these four components one by one. First is the pathogen, and second is the patient, and the third is the hospital, and the fourth is the local one. And about the pathogen, the risk of a particular AMR pathogen in a specific location should be assessed at multiple levels, such as a global, national, or local. And the factors you need to consider is the whether the resistant pattern phenotype is usual or not, and if the pathogen is extremely drug resistant, it is very serious. And also, if the resistant gene is on the plasmid, it can transmit through beyond other species, so it is highly transmissible. So this is, if you find out these findings, then the event might be high risk. And also, if the pathogen is not previously reported globally, this is very important. And the local epidemiology is also important, even though in other regions, it is not so quite unusual. In some particular area, it can be very unusual. So the level of the risk assessment, pathogen component is also important. And about the another thing that you need to consider is the the spread of infection, and if there might be a significant number of patients are affected, then it can be a high risk. And also, this is the patient component. But the treatment options, if you have some limited treatment options, the event can be high risk. And if the pathogen is highly pathogenic, the E. coli or Klebsiella pneumoniae is more pathogenic than the Acetobacter baumannii or Pseudomonas aeruginosa. So if the pathogen is highly pathogenic, the event can be of high risk. Yeah, this is the same one. And also, you need to consider the hospital components. If the affected hospital is the hospital that is very important in the region or in the country, such as the national pediatric hospitals or national cancer center, the event can be high risk. And also the capacity of each hospital is a critical issue. If they have a very good infection control team, then even though the event itself is similar, the event can be overall risk. However, if the hospital does not have a good capacity to respond, then even the same or similar event can be of high risk. This is very resource demanding. And if you think about the other hospitals and some of the AMR pathogen can transmit beyond hospitals, so the local components is also important. This is closely related to the capacity of the public health centers to respond. Even though the outbreak response of the AMR pathogen, AMR outbreak, is the primarily on the hospital IPC staff. However, the public health centers or public health authorities have also a role. They need to look for the local components, and if there's any possibility of the local spread of the AMR pathogens, then that event can be of high risk. So after the assessing these 4 components, you can assess the overall risk. You can decide this is based on the assessment result of each component. It can be very subjective. So you need to do the risk assessment in a team or with key stakeholders. And you can justify, even though this is very subjective, you can justify as a team. Sorry. And if you justify the result of the overall risk, then you can proceed the next step, next control measures with the confidence. And in Japan, we have the joint risk assessment within our team, and sometimes with other key stakeholders. And this kind of the communication or meeting is very important for risk assessment. And there's also the area of uncertainty. How to decide overall risk based on the assessment of each component. This is very subjective, so it's still unclear, and we are now working on how to solve this, contribute these activities, and also how to assess the risk once new clinically significant AMR pathogen is detected from the animal, food, or the environment. It's still under discussion, especially about the environment. We have the next session is about the wastewater surveillance. So if we find out some particular very important AMR pathogen from the river, then how to do next? This is very important part, but still under discussion. And also how to evaluate this methodology of risk assessment of AMR outbreak. This is also a very new area, so we are now working on this. And after we assess the risk and we trigger the outbreak response, then we move on to the investigation of the AMR outbreak. And this is the photo of the outbreak investigation in Japan. We have the FPTP colleagues, and we have a training program for 2 years training program to learn how to do how to investigate the outbreak. And there are 8 or 10 steps for outbreak investigation. This is basically based on the US CDC's guidance. However, we have many modifications, but still verification, case definition, and active case findings, and the observation, and the descriptive epidemiology. And this is the main course of the mainstream of the outbreak investigation. And if there's any need for further investigation, you can make the hypothesis and test hypothesis. And you need to do response all time, anytime. And after that, you need to make a report to share the experience. So this is a nearly final slide of my presentation. We have the WHO Western Pacific Regional Office have developed the one guidance document to introduce responding to outbreak of AMR pathogen in healthcare settings. And these 10 steps, they include risk assessment. Actually, I included. They include the risk assessment, and it is a really good document. And please refer to this if you want to learn more. And this is a final slide. Take-home message. The risk of an AMR outbreak should be assessed to determine if escalation of response is needed, because timely escalation is a key to contain them. And factors related to pathogens, patients, hospitals, and local contexts should be taken into account for the risk assessment. And early reporting to public health authorities is important when healthcare facilities may not have the capacity to respond. They need to work together, public health authorities and the hospital staffs, and communicate early that support may be required. Thank you for your attention, and sorry for my bad connection and bad slide. Slide shows. Thank you very much.
Thank you, Professor. I'm just going to turn on my camera for a second. So video, yeah, okay, there we are. I think it was fine. Everything was very good except the first few slides, because of the slides weren't moving. So I think a few people have made a comment, but I think we can make the slides available on the portal.
Yes.
Is that right, Terence?
Yes, of course.
Yeah,
we will make all the slides available on the portal, and yeah, I will also put them out in French, because we're going to do French language webinars.
Okay,
very important.
So so we can start with, Professor, just on I'll kick this off. I'm just waiting to see whether other questions are popping up, so I can follow the questions from others. So as you know, from a practical point of view, do you think the local, I mean, obviously local reporting is really important, but should the whole thing be coordinated by a central body or central organization, or can local people do more by themselves? What do you think about that?
Thank you very much, Dr. Tousy. It depends on the local capacity. If they have the capacity to respond, the local government or local public health centers can work with the one hospital. However, not all the areas can do that. So in that case, the central government or central body, such as the National Institute, have some role to coordinate or to support.
Yeah. I think that this will come into our next, merge into our next topic of the no blame or no responsibility, I call it, because I think the no blame concept, it sounds really good and it caught on, but there's some discussion about that it's not about no blame, but no, it's about proper accountability. And not necessarily the individual accountability all the time, so blaming individual, but more about looking at the system also and see where the system isn't supporting. So what do you think about that sort of the fear of reporting? Is that a major issue, you think, in some places?
Yeah, thank you very much. The fear of reporting, there are almost all time exist, and the hospital staff here are very worried about the reporting their fault. Sometimes they feel that they have their own fault. However, it's not. Maybe it's not their fault. So for the public health side, sometimes they judge whether it is good or not, but it's not so good attitude. So they need the attitude that they need is to support the outbreak, to contain outbreak itself is the goal. If they share the goal, then they may avoid some conflict and they may decrease the fear from the hospital staff.
Yeah. And I mean, still waiting for other people to say, ask questions. But I mean, as far as, so you think, I mean, I know there was a lot of rumor and stuff during particularly COVID-19 outbreak on, how, and some others as well, actually, in MERS, so Middle East respiratory syndrome, acute respiratory syndrome, there was issues where the people who originally reported, you can understand that health authorities and people want to suppress because they want to decrease the general fear. But at the same time, suppressing reporting people can be a mean that's delay in recognizing. I mean, we only were in UAE. I know that it was only like announced the pandemic, COVID-19 pandemic was only announced sort of, I think, in February, March. But in our hospital, I know we saw cases that I think were more than likely due to severe COVID-19 people who actually passed away, but as early as January. So, it didn't come till much later, recognition. And I think that maybe that delay can make a big difference in, our ability to contain any outbreak.
I totally agree with you. The delay of the reporting is really have some disastrous outcomes. So we want to we need to avoid that delay. In that case, we do not, or we should not blame the reporting people. They are oftentimes they are the hospital infection control staff, infection control nurses. But it's not their fault. So they are combating their frontline people. So we need to express that the public health authorities also want to support. This kind of attitude is very important and can avoid delaying the reporting.
Yeah. And I mean, I think, well, maybe I don't know what you think about this, but maybe we should avoid trying, reporting that immediately goes to the media. I think, or using social media. I think there needs to be much open channel of reporting within the national bodies and stuff. So it should be an open path to reporting and response from them, rather than people feeling they're not getting a response and they have to go to non-standard avenues, which can then cause more problems. So I don't know how you're in the central body. How do you have a dialogue, ongoing dialogue with people so that they don't feel that they know you and they trust you?
Oh, it's very difficult to explain, but the continuing dialogue is very important. And the risk assessment is if there's 10 people, there's 10 risk assessments. However, we need to through the dialogue, we can find out one good common risk assessment. So the continuous dialogue is maybe just the one important key point. Continue.
Yeah, thank you for confirming that, Prof, from your experience, that this continuous dialogue, I think, is very important. Gareth, do you have any further comments on this?
Yeah, several comments on the no blame attitude. I have reviewed a lot of studies on outbreak infection and on patient safety, or rather adverse event in healthcare. And while most countries have national program on AMR, which includes the no blame attitude, it is not being implemented practically anywhere. The situation is, even in European countries, that if adverse events are reported by patients or family of patients or healthcare workers, the immediate reaction is often to fire the healthcare person alleged to be responsible, or whether he or she is in fact or not, is to fire someone. And I remember distinctly some training done by Professor Philip, then working with the WHO. And he asked a room full of people, head of hospitals and physicians from, I think it was at least 15 countries or so. What happens when you find that one of your staff has committed an adverse event, such as a break-in infection, which resulted in an outbreak? What do? Do you have hold a team meeting, or do you fire the person held responsible? And 99%, I think all hands went up except two, saying they would immediately fire the person held responsible for the outbreak. So I think that was back in 2018, I think, but it is still the case from what I see of all the in-depth report that I've read from quite a number of countries. And there is really a problem. I mean, healthcare systems don't want to admit there's a problem in patient safety. The WHO latest figures say 4 out of 10 patients die from an adverse event in healthcare systems. And even in the National Health System of England, it is estimated that there's over 100 million medical errors in medicine per year. That's the figures from Sir Liam Donaldson, who initiated the program. And those are the figures from 2 years ago. So it shows the problem is enormous, and the problem, I think, will not be resolved unless there is, as Sir Liam argued, a systemic approach, which you are outlining very well, a systemic approach to remedying medical errors, as opposed to just firing somebody or yelling at somebody or punishing somebody. Because if that somebody leaves, the mechanism for the error is still in place. So it will lead to a lot more infections, a lot more adverse events. And those adverse events can really kill and do kill a lot of people. So, like we hear over the past few days, there's been an enormous amount of talk on AMR. And I see a lot of things saying that, patients in Africa are taking too many antibiotics. But you have to have a situation in which infection prevention control or even safe order is not a reality in Africa. So we have to defend our brothers and sisters from developing countries and say we must have the conditions to do proper outbreak investigation. We must create the setting in which people have a right to not walk out of healthcare system with a new infection. On that, I'll make a last comment from the Assistant Director General of the WHO, my friend, the Irishman. He was talking to the executive board about the outbreak of Ebola in RD Congo. And he said, I have to tell you that 86% or about of Ebola cases were caught in healthcare systems. Mothers, Congolese mothers would bring their children because they had diarrhea or any problem whatsoever. They would bring the child into healthcare, and the child would catch Ebola in healthcare system. And that's how the Ebola epidemic killed, over 10,000 people. So the fact is, if we have an epidemic anywhere in the world tomorrow of bird flu, like there's a real risk today, or a really pathogenic, infection. The fact is, we don't have presently, maybe you have in Japan, but in most of the world, we don't have the proper structure to do outbreak investigation and stop these. And I think that I really appreciate your intervention, and I think it has to be part of a movement to make sure that health systems have that. And it will save a lot of money to the hospitals. It will save a lot of money to the health systems nationally. It will save money. It will reduce insurance costs, and it will save lives. And I'd like to make a call for that. Thank you very much.
Yeah, many thanks for those very, very insightful comments, Grant. Your experience is always highly appreciated. I think there's some questions here, just picking up on the people coming. They're interested, obviously, in the common things like use of antibiotics during frequently use of antibiotics for influenza, particularly, or viral upper respiratory infections. I think they didn't. It's not says where the attendee is from, but that's something I think that's not uncommon in most places. Certainly, I've faced this in my own departments, in that overuse of antibiotics, and we try to discourage, people prescribing by educating maybe the people more. But it's always a difficult one, because parents are obviously worried about their children or whatever getting worse. And if you don't give them antibiotics and then they get worse, what do? Do they come back to the hospital and wait again? Because often there's a wait involved in the coming back to them, or a cost. If it's a private institution, they may have to pay again. So they want to get everything in one go. And that is, I think sometimes that's the challenge. Also, it's so difficult sometimes to differentiate between viral and bacterial, upper respiratory, especially pharyngitis or something like that. I think in my own approach, I'll talk about personal level, because I think it's easy to talk what I do personally. Obviously, if it's obviously viral, there's no clear focal infection like tonsillitis or pustular tonsillitis, then I try to ensure that the parents understand that's likely to be viral, and it will take a few days and get better with supportive therapy. But sometimes if people, you can't convince every mother of this or everything. So what I tend to do, I do use this, delayed prescription sometimes, which is basically I give them the prescription separately, but say that please don't pick it up right now. See how it goes for 24 to 48 hours. If the child improves, don't give him the antibiotic, because it can have side effects, etc. I scare them a little bit. But if it doesn't, if he isn't, and you're worried about him, then you can pick up the antibiotic and start. So, I try to, maybe that makes a small difference to the number of people who use antibiotic. But it's a difficult area. Do you test for viral, rapid test for viral influenza and stuff? You can. But again, they're not 100% sensitive or specific. So it's always difficult balance. But we need to educate the people and scare them about, a little bit about the overuse of antibiotics and the dangers of that to the community. The problem is obviously and I think Prof can talk about this, is the danger to the individual versus the danger to the community. So what we're talking here is about, AMR problems to the community. On an individual level, sometimes you say, oh, maybe for me, I just take it. Why don't I just take it? But you don't understand what damage that's doing to the community, but also to yourself, to your own good bacteria, the good microbiome. So it's a difficult balance. We need to get more health awareness. I don't know if you guys have a comment on that particular issue. Gareth, do you have any comment on that or any thoughts?
Well, as I'm an economist to start with, so I was a bit dismayed by the introduction of behavioral economics and financial, as opposed to industrial capitalism 30 years ago. And I think it's the same in health. There's too much of a tendency in health to focus on the individual behavior of the individual, which is parallel to the economic distorted view, which is to say that I, as a consumer, am responsible if I don't buy the right kind of food for my kid. If my kid is sick because I'm not buying the right food. I think that there has to be, a proper responsibility on the part of the people producing the food. So I tend to be to try to think in terms of systemic, resolving problems such as overconsumption of antibiotics from the standpoint of the organization of healthcare. I want to mention a proposal that came out 10 years ago when I was in Senegal from the Patient for Patient Safety Group, which we had, which was that a number of healthcare people, including physicians, pediatricians, nurses say themselves they had seen bad practice in healthcare, or they had themselves made errors. And they said the problem is that if it's reported, then we get fired, we get into trouble. So the elaboration of a project we had, it was a whole week-long seminar. The idea was that to create a center point in which people could, it's sort of like a website managed by very knowledgeable physicians and people, you know, responsible, that would take in all the complaints, all the problems of adverse event, of not properly, you know, managing antibiotics and others. But it would be done in a way that the individual could be checked with the management, but could be reported anonymously. In other words, that if there were errors, the person could not get fired for reporting that he or she made an error or his colleague made an error, which is a very big problem in the no blame. I think, you know, I've in preparing for my intervention in Dubai last May, I reviewed about 12 years of the 10 years of the patient safety and of the intervention of Sir Liam Donaldson. By the way, he said he's sorry, he had other commitments today, he couldn't be with us, but I'm corresponding with him. And Sir Liam Donaldson has, you know, ever since he initiated patient safety, he has lamented the fact that the no blame attitude has not been adopted in healthcare. Just the last comment, what Dr. Tousy said, I mean, it's very good that, you know, stewardship. I think stewardship at least in the advanced healthcare sector, right? Not in poor countries, but in the advanced healthcare sector, we have had very good stewardship established on hospital level, but it's not always respected. You know, that's one thing. But still, it has been done. However, let me backtrack with one thing. I saw the data from the English healthcare system, and they were the only country, to my knowledge, I don't know unless you did in Japan, to record hospital-acquired COVID-19. And over 1 year, they estimated, it's public knowledge, that they had 110,000 COVID-19 cases were caught within healthcare over 1 year. This is huge. And as we know, unfortunately, cases of COVID-19 also led to overuse of biocides. Overuse of biocides do create AMR in the environment. And, you know, it created also a situation in which a lot of antibiotics were used, which should never have been the case. So, you know, 100,000 people came into healthcare for a broken toe or a flu or whatever, and caught COVID-19 in healthcare in 1 year. And it's, you know, we have to praise the English for having done that, but it shows the extent of the problem as we're facing the possibility of other pandemic tomorrow and the fact of the AMR toll. I think the official figures are really under what is the real situation and what is the real threat. And the real threat has to be approached on a systematic industrial basis and not just responsibilizing the person. Thank you. Thank you very much, Takuya. Thank you, Naeem. Very good.
Are we going? I'm just waiting to see if Dr. Amir appears at some point. So I think just looking at the comments, people are making some very good comments about spread. I think further to what Garen said, what I would say is, you know, other than antibiotics, using of antibiotics for influenza on an individual level, you know, I think what she mentioned, I think I would encourage, I would do a plug for our later webinar on airborne transmission, is that maybe we also should be looking at ways of decreasing spread, for sure. I think, you know, even simple infections like influenza, viral infections, you know, they're seasonal, they affect during school. and so ventilation systems, I think Gareth we'll come to that during our later seminars, the influence of ventilation systems on these infections and how they maybe exacerbate. So the problem isn't just treating antibiotics, how do we prevent spread of easily transmissible airborne infections and others, because obviously Gareth will come to this. She mentioned Ebola, and I think we don't understand all of the transmission characteristics of every single virus yet, and needs to be a lot more research looking at ways of preventing spread and how to improve our urban design to prevent or limit airborne spread. Then obviously the role of vaccination is a separate issue, but I think all of these tie in together to hopefully reduce infections. Just a final point I wanted to make was on reporting. I think one of the difficulty I always found that it's like, okay, please report this, and there's a huge form to fill, and people, they don't have time. So it's not just about low blame. It's so I think there needs to be, maybe Prof is here from Japan, which a very advanced country, and with modern technology, maybe with AI and whatever, there can be systems in which it'll be much easier to report near misses or possible problems, and that then generates the report by itself. So you don't need to spend a lot of time, and that might encourage people to report, and for the AI then to look at the patterns and report that much quicker than having individuals looking at reports, and it's much more cumbersome. So maybe there's a role of technology, digital technology for that. I don't know if you have any comments on that, Prof.
Professor, you want to come back in? Takuya?
Dr. Tousy, yes. About the reporting, we have also similar challenges. We still have the fax. We're still using the fax machine, and the doctors, through the COVID-19, we make local doctors to report it directly to the country, to the national level. However, there are many mistakes, so the local governments need to check, and furthermore, so there are many further activities other than that. But you are
Takuya, where do you see the future? How are countries picking up? I know you did training in Malaysia. How do you see it? Can you do training specifically, seminars with healthcare staff in other countries?
We have the outbreak response seminar, our workshop in Malaysia, Brunei, Philippines, and Mongolia, and the Cambodia. And I found out that there are many tension between the hospitals and the local or national governments. In some countries, they are really reluctant to reporting to the AMR outbreaks. So it's really country dependent, local dependent. But to make reporting easier is one key. Just like the Dr. Tousy mentioned, the AI or some new technologies can make it easier, and it can facilitate reporting from the hospitals. And we don't need much information, just reporting. That there might be some outbreak. This kind of information is enough to trigger or to start risk assessment by the local governments.
I'm glad to hear that even in even in very advanced, what we perceive as very advanced countries like Japan, we're still using old technology like fax sometimes. So okay. I think yeah. Sometimes it's good because sometimes more upcoming countries, like low-income countries, are quicker to adapt or adopt. Have the old technology, so they just go straight to the new technology. So sometimes some of these emerging markets can be can teach something to the more advanced countries like the UK, for example, where because of established systems, it's more difficult to get rid of old technology and move to newer ones. But thank you for your comments on that. Go ahead, Garen. Sorry.
Yeah, I said absolutely. I've seen the reports in many African countries, in particular, people say they don't have the time to fill in a 20-page document to report on adverse events. They just can't. I mean, they would be putting their job on the line if they took the time to fill in those documents. So that national AMR program that have very, very lengthy document to fill in for any problem. I mean, they're not living in the real world. And it's good you mentioned AI and ChatGPT. We have to work on that.
So, Dr. Tousy and Gareth, one comment, an additional comment. There's challenges for reporting, and at the same time, there's a difficulty in finding out or triggering the outbreak response through the routine surveillance. Sometimes many countries have much data, but it's really not for quite the how to say it's even though they have some outbreaks, the local public health authorities or national public health authorities do not trigger the outbreak response. Yeah. So the methodology of the risk assessment need to be more how to say, they need to be more accustomed to do the risk assessment through the IBS.
Yeah, I agree. I mean,
I was just told, attendees took some time to get on, but I just was told that we have 1,133 people listening to us, which is good.
Great.
So I don't know if Dr. Amir, is Dr. Amir coming on?
Yes, she's coming.
Dr. Amir is coming on.
Right, great. I think apologies for we have a lot of interactive discussion between Prof. Gareth and myself, but I think this is useful because I'm looking at what people are asking, but I'm also we can add from our various experience comments, which can be useful for these attendees. And if they have any specific questions from this, that they can go straight to the Q&A box. And I'm looking at that, and we will definitely deal with anything. I'm just curious. I'm just also keen to listen to what Dr. Afreen or Professor Afreen Afreenish Amir has to say as soon as she is on. We do have a little bit of time still left on this webinar, so we can benefit from that.
Be ready in 1 minute.
Yeah, no problem. That's fine. If there are any questions, guys, I mean, from the attendees, please do put it on or comments. It doesn't have to be a question. Your own feelings or about the topic. I mean, obviously, there was some interest in COVID-19 and use of azithromycin. I'm not an expert on COVID-19, I must say, but the thing is there was a lot of different things tried, and problem is a lot of it's anecdotal data. The problem was that during an outbreak, it's hard to get evidence, proper evidence based on cumulative data, because it takes time to get that and to actually compare use of drugs versus placebo or not, and see if it's any benefit. And analyze that data. That takes time, and so it's very easy to sort of grab on to different things, different medications. That this works, this doesn't work. And people try different things, and then sometimes, and that's okay. But the thing, sometimes politicians jump in, and they will support something without the evidence being there, sort of jump over the head of experts. I'm not saying experts are always right, because there's always issues with experts as well, but I think politicians can make the things a bit more complicated. I won't say worse, but so we need to be, certainly in these discussions, we need to have create our own mechanisms of experts where we can go through data quickly and come up with recommendations that whether something works or doesn't work, and designate maybe places where this can be tested under control situations, rather than randomly people using medication. So yeah, I don't know what you think about getting data quickly during AMR, sort of outbreaks. So surveillance is good, but how do we get data on efficacy quickly? Is there a way to do that?
Efficacy. A very difficult question. Efficacy is
The big
very
topic, sorry.
To evaluate, and many countries have their own surveillance systems. However, it's really difficult to compare it inter-country, and they have many drawbacks in their own systems. They need to do the surveillance evaluation for each systems. And in Japan, we have the several systems, but the one thing that I'd like to insist on is that the single surveillance cannot cover everything. So you need to utilize the multiple sources of information over surveillance. So in many countries, there might be at least one surveillance, but they need to utilize more. It's not, you don't need to utilize the surveillance, but the information is also important. That is the EBS. So multiple sources of information is very important to utilize it.
Dr. Yamagishi, thank you very, very much. Please stay with us while we introduce Dr. Afamish Amir. I'll let you introduce yourself.
Hello, yeah. So I'll just very quickly mention, I mean, I probably know much. I only really got to know you recently, and I'm very impressed by, obviously, your profile. But Dr. Afamish Amir is Project Director of Antimicrobial Resistance and the National Fungal Disease Surveillance System in the National Institute of Health in Pakistan. And she has experience and training in many, many different places. In leadership, and is in a good place to provide leadership in and we would really benefit from her, I think, experience, particularly in Pakistan, which is I guess a low-income country, but with a huge country with which challenges, and her experience in that would be very useful to hear. Thank you, Dr. Afamish. If you want to just give your comments on how you want to proceed.
Thank you so much, Dr. Naeem and Garance, for inviting me to this session. I hope you can hear me well. Yeah, thank you so much. So thank you for the very nice introduction, and I'm honored to be part of this today's session. And it's a pleasure to hear from you and learn from you as well. So I've been working as the project director for the fungal disease surveillance in Pakistan. So this is the first time we are setting up a fungal surveillance system across the country, and we are setting up 14 mycology laboratories. And my background is I am a medical microbiologist, and I'm working in the field of antimicrobial resistance for the last 8 to 10 years now. And I've established I've done a number of work in the country related to surveillance, stewardship, and advocacy. And apart from this, I'm part of many international commitments, like I'm part of technical advisory group for Fleming Fund as well. And today I would like to discuss, if you allow me, I can share some of my experiences related to the fungal infections and the growing burden of the resistance, and how we can mitigate it through stewardship practices. I can share my screen. I'm trying to open the link. Just give me a second. Yeah.
Can you manage? Yes, to share.
I just need to ask, when I'm going to that share part, I can only go to the folder section. From there on, I guess I can go towards that presentation.
You don't have a share screen icon? No.
Now it's here. I'm sorry. Just looking at it.
Okay. There we can see your screen, Dr. Afamish.
Okay. And I guess I have 15 to 20 minutes to share some of the thoughts.
Yeah, go ahead. I think we had problem before moving slides, so just be careful about that. We will let you know if there's any problem.
Yeah, is it working now?
Yeah, it's on. I can see the screen. You want to just go to the next slide just so we can see it's working?
Yeah, this one is the first slide.
Okay.
Okay.
Yeah, it didn't move to the second one.
This is the I moved to this first slide. I think if you're able to see it, or
you can see the first slide. Yeah. Although it's on the slide mode, not on the slide show mode. You know what I mean?
Okay. Give me one more. Yeah. Okay, so I'm talking about the antifungal resistance, the point, right, and how we can mitigate it through the applying regular antifungal stewardship practices. So talking about the burden of the disease, you can see that around 13 million people of fatal fungal infections worldwide daily, and more than 2 million people, they die from the fungal related causes yearly. So this is like a huge burden, and this makes the fungal infection the 5th largest cause of death. What are the causes?
We see the slides.
We can't see the screen actually now.
Okay. Let me see. Can you see the screen now?
Yes, yeah, it's visible now. We're on the causes of antifungal resistance.
Yeah. So the causes of the fungal resistance is like the same we talk about the bacterial infections. It's same like the antibiotic resistance that we are facing. There is a use of misuse of the antifungals, and in the LMICs and in the resource limited settings, the biggest challenge is the diagnostics. And what we see is that there is many prescription of the antifungals without any proper lab diagnostic cultures. And this is the empirical treatment towards the fungal infections. And then we see that there's a huge overuse and misuse of the antifungals. This exposures of the antifungals making the fungi more familiar to the antifungals and making them more resistant to the antifungals. Then through the clinician's point of view, what we see is that there is inadequate dosing and the treatment duration changes over the time. That again is a challenge to that we see with the resistance. Over the years, the development towards the antifungals drug development is very low, is very slow as well. And it's a challenge to identify the right drug target. And there is very limited antifungals that are available right now for the treatment. There is a huge use of the antifungals in the agriculture system. And then the most important factor are the very important climate change and the environmental factors, which are helping the fungi to propagate. And so the clinical implications for these fungal infection is high. We see high treatment failures. We see high mortality and morbidity associated with it. The people with the fungal infection, they have to have a long hospitalization and they undergo a prolonged illness. That causes a huge burden on the healthcare system. And the biggest issue is that we have limited treatment options available with us. So we have to be very much careful. And the global estimate says that the annual incidence of the invasive fungal infection is around 6.5 million, and which is associated with 3.8 million mortalities, of which 68% they are attributable to the fungal infections. So what is the challenge? Challenge is the emerging antifungal resistance. We have yeast, we have the mold infections, and we have the dimorphic fungi, which are causing infection in the humans. And over the years, we have seen that all of these different types, they have shown resistance to the available antifungal agents. Some of the resistant mechanisms, they are intrinsic, and many of them, they are acquired over the years because of the climate change, environmental factors, and many mutations that we see within the fungus. Some of the common mechanism of antifungal resistance include the target modification. We see that there is altered enzyme structures. We see efflux pumps, which are helping the fungal cells to remove the drug out from the cell. We see the enzyme degradation mechanism that leads to drug inactivation. And then we see that there are some fungi which have the capability to produce the biofilms, and that eventually leads to the reduced drug penetration within the fungal cell wall. Among the antifungals that I have just discussed, we have a limited options available with us. Polyenes, among the polyenes, we have amphotericin B. Among the group antimetabolites is the flucytosine. Allylamines include the terbinafine. And among the azole, we have some larger group, fluconazole, itraconazole, voriconazole, phosphonazole, and isovoconazole. And echinocandins, we have caspofungin, endulafungin, and micafungin. The challenge that we see within the resource-limited settings is the availability of these antifungals. Many of these antifungals, they are not available at the tertiary care hospital level through the government-funded projects, through the government funding. Like what we have seen, there's a lack of the antifungals within the essential medicine list. And there are many reasons to it: the availability within the country, the high cost of the antifungals, and very recently in Pakistan, the caspofungin has been launched, which is a big relief right now. So like we have the option available with us for the treatment of the antifungal infections. The spectrum of the antifungals against different fungal species are shown over here against the yeast, mold, and diamorphic fungi to give you a glimpse that how effective these antifungals are. When we talk about the amphotericin B, it has a good spectrum against all the major Candida species, and it is good against the Cryptococcus neoformans as well. Among the azoles, only Itraca, Vorico, and Posaconazole, they have effectiveness against majority of the Candida species, except the Candida glabrata. And echinocandins, they are good against all the Candida species. When we talk about the molds, particularly against Aspergillus fumigatus, we see effectiveness of amphotericin B, itraconazole, voriconazole, and all the species of the echinocandins. For the dimorphic fungi, we are blessed that all the amphotericin B, they are effective, and among the azoles, we see a good spectrum as well. The challenge is huge that it has been highlighted by many of the bigger organizations. WHO has issued the fungal priority lists. CDC, this picture is from CDC, that have shown that the urgent threats, among the urgent threats, they have clearly mentioned about the emergence of the Candida auris. And this is a pathogen of concern in our country as well. And in my fungal surveillance, the first priority pathogen is the Candida auris. And on the left side, if you see that since 1950 onwards, as soon as we see the development of the fungal antifungals, the resistance also emerges after a few years. Like, for example, if we talk about in 1980, ketoconazole has been introduced, and what we have seen that after a few years, there we see the treatment failures in the community. And likewise for the other agents as well. Particularly when I talk about the Candida auris, since 2000 onwards, we have seen almost 95% resistance against azoles, and almost 60% resistant to amphotericin B. And for the echinocandins, we are it's not resistant, but some of the countries, they are reporting pan-resistant strains of Candida auris as well. This is the fungal priority pathogen list I have just discussed. The pathogen, the priority list has been developed, and it shows it has been developed after a very rigorous process and mainly targeting the research and the policy interventions. In the critical group, you can see Candida albicans is there, Aspergillus fumigatus, Candida auris, and Cryptococcus neoformans. Candida albicans has been the highest reported pathogen among the all Candida species. And over the years, there are chances that we can see some resistance against Candida albicans. Auris is very common, as I've just discussed with you. So, and not only in the Candida and the molds, this picture is showing that there is a geographical distribution of the resistance mechanisms. If you see that we can see azole resistance in airborne Aspergillus, we can see resistance to the dermatophytes, much reported from India and also from South Asian countries. And we have seen Candida auris. I can show you in the next slide about the Candida auris. Here you can see that this is again a very good study that has been published back in 2021, and that has shown the emergence of the dermatophyte resistance across different parts of the world. And you can see there are many studies that are published from Asia, from Europe, from India, from USA, that shows that dermatophyte resistance is there, particularly against terbinafine, which is a matter of concern across all the clinicians. Candida auris, if we discuss in detail, that we are working with CDC US in this project, and this is a picture from their epidemiological studies. Since in 2015, the Candida auris has been reported from few parts of the world, and since the data has been coming up in 2019, we can see that the Candida auris has been reported from across almost all parts of the world. And here, So what are the mitigation measures? What are the interventions that we can do? So this is a very busy slide, but I would take you towards the last part, which is the interventions. And the interventions suggest that there should be environmental antifungal stewardship. There should be a surveillance mechanism that should be gathering the data and to identify the trends and patterns within the country, and also understanding the emerging pathogens. So one of the key factors that is highlighted in this AMR Awareness Week as well, that we have to educate, aware, and educate and act now. And for this thing, I think the role of the stewardship has been highlighted for since after the last 10 years of efforts on the AMR. What we have seen is that we are doing a lot of work on the AMR thing. We are promoting the quality diagnostic services. We are promoting the development of the antimicrobials. And but the biggest challenge is that we see is with the clinicians and with the community and the patients. And that can only be considered through a very rightful stewardship approach. The behavior change, the social change is required, and that can be the only good solution to act against the antifungal resistance. Antifungal stewardship is a coordinated intervention, and the aim is to improve and measure the appropriate use of the antifungals. And this can be eventually lead to promoting the selection of the optimal antifungal drug regime, their dosage, their duration of therapy, and the route of administration. It seems a little complicated, but through a very set of activities, we would be able to achieve antifungal stewardship. The rationale is very much clear to all of us that why do we need stewardship? One of the factors that I have just discussed is a growing antifungal resistance. And what we see is that with the invasive fungal infection, there is a high mortality rate that is associated. And the other thing is that in many resource-limited settings, the biggest challenge is the availability of the diagnostic tools. All the fungal diagnostic tools, they seem a little expensive, and they need more expertise in terms of human resource. So there is a less availability of the first the diagnostic tools, and then maintenance of the tools, and then their utility, and then the generating the right results. We see there is overuse of the antifungal drugs in not only in the human sector but also in the agriculture sector. All the antifungals, they are associated with high toxicities. So that makes it a very good rationale that there should be a more promotion towards the antifungal stewardship. Many of the fungal infections, they are in the immune compromised patients, which already have some comorbid condition with them, and they are already taking they are already taking some other medicines as well. So there is a huge chance of drug interactions, and that needs to be considered for the stewardship. The cost of the antifungals, that is the biggest issue. It is really high, and many of the hospital formularies, they do not have the antifungals within their system. And the other points I have just discussed with you. So talking about the mitigation measures, the 7 core elements of the antifungal stewardship that has been suggested by CDC, that involves the first step is that you have to have a very good leadership. Until and unless you have a good leadership, you won't be able to develop a system, to act on the system, and then to monitor the system. So the leadership should be there. There is a commitment. There should be a commitment by the hospital authorities and by the institutions, and eventually the provincial level or the national level, that we have to develop a stewardship team. The other important thing is accountability and responsibility. Very important that everyone engaged in the stewardship plan, they should be accountable and responsible for their acts and for their activities. The key practitioners, the ID physicians, the pharmacists, they should have a very good understanding. They should be responsible for their own interventions, and they should have a very right clinical experience. Expertise on the infection management, very much required. If we talk about the laboratory persons, if we talk about the clinicians, if we talk about the pharmacists, all should have a relative understanding of the infection management, what is the pathogen, what drug should be prescribed, if we require any IPC intervention, that should be well understood. The fourth thing is the education and training. The element of this ongoing education and training, this is important. The refresher training concept is important. That the results that are generated by the microbiology laboratories, that should be discussed with all the clinicians and the pharmacists. So they have a common platform to understand the trends and patterns of the fungal agents. Responsible use of the antimicrobial, which is the essence of the stewardship. The ID physicians, they should be the one working very closely. There should be post-prescription reviews and feedbacks. And I can show you in the next slide that this approach that really works. That really works, that we have to have a very good interaction with the pharmacist, with the microbiologist, with the clinicians, and to understand the patient status and de-escalate or escalate the antifungals accordingly. Monitoring and surveillance, a very important key element of the stewardship that helps to understand the data, that helps to understand the trend, the patterns. And the important thing is that that helps us to understand that if we are going in the right direction or not. Reporting and feedback, track and benchmark the antifungal use, assess the patient level outcomes, and feedback to the prescribers. So these 7 core elements, they need to be established to have a very good stewardship programs. And I can give you some of the examples across the globe that the stewardship programs have been developed, and they are following the same patterns and same route, and some good success stories are there as well. This is one study. What we see is that how the stewardship program, they are effective. And you can see that this study published back in 2013, and this is a 6-year-long anti-stewardship program in a teaching hospital. That really shows that by the end of all interventions, that the favorable outcome towards candidemia has been seen. If we see in 2007, 2008, 2009, and 2010, ongoing, we can see that the process of care measures regarding the management of candidemia, they have been improved a lot. Similarly, another study that shows that how the intervention has helped. If we talk, if there's an intervention, the clinicians were discussed about the use of the certain antifungals in their patients. And if we talk about the first drug, like liposomal amphotericin B, the number of the advices given were 78, and 25 patients, they were switched to drug with a narrower spectrum. And 25 patients, they were advised about the interactions or the adverse events. And 51 patients out of 78, you can see that they have switched to the lower, narrower spectrum, or even they have stopped the therapy. So you can see that the interventions, they do work. If we talk to the clinicians, if we do some interventions, we can see the change in the pattern and the prescription behaviors. Similarly, in another study, here I just want to highlight about the last part of this busy figure over here, that this is trying to show that how much is the impact of the intervention. There is some discussion related to the cost, pre-intervention and after the intervention. And you can see in the last, they have mentioned that the global saving of all this intervention mechanism was high. Like we have seen around $370,000 has been saved because of the intervention mechanism. Because the antifungals, they are really expensive. And if we go and towards the de-escalation, towards the switching of the therapy, we see a very huge impact on the healthcare economy. Another study that was published in 2022, very recently, from a Brazilian tertiary care hospital, and it has shown that how much intervention has helped. In the first audit, then when they have started their survey to understand the prescription behaviors, they see that 80% of the prescriptions, they were inappropriate. And during the second audit after the intervention, they have seen a reduction into the 64%. Similarly, when we talk about the administration route, another example, from 64 to it has reduced to 50%. So that is the biggest thing, that when you intervene, you discuss, you can help the patient and eventually the healthcare systems. I think this is the last slide. I can stop over here. So it seems a little rigorous. It seems a little challenging, a huge system that needs to be established. You need a multidisciplinary team. You need epidemiology and surveillance mechanisms. You need a professional training mechanism. You have to have a good laboratory systems. But we all have to work together because it's all about the patient safety. So I stop over here, and yeah, thank you so much.
Thank you very much for that sort of comprehensive review, particularly targeting something that's quite difficult, I think, fungal infections. So I just wanted to very quickly, I think there's a few questions I will ask more with your microbiology hat on, but one thing, how much do you think was the proportion of primary fungal infections versus those which I would call secondary, which are, i.e., in those with immune suppression, etc. So, do you think, in Pakistan particularly, I guess it's more important than it's probably different from more advanced countries or in an agricultural society. So, just give me some idea what your comments about that.
Yeah, the fungal infections, they are more common in the immune compromised over here. And we have a good connection with the dermatologist across the country, and we see that they are seeing many of the fungal infection like skin infection, nail infection, hair infections, but morbidity is much less associated with them. And many of the times, because of the long duration of the treatment, they are even not reported to the clinician. But immune compromised patients, in them we see a huge burden of the invasive infections, particularly candidiasis. Particularly, we talk about the cryptococcus infections, they are high. And then pulmonologists will keep on reporting a high burden of the aspergillus infection. So in the immune compromised, we see a high burden in the hospitalized patients because of the comorbid condition as well. And then we see in the Candida auris, I can give you the example. Candida auris remains in the environment for a longer period of time. And in one of our hospital settings, we have seen a huge outbreak of Candida auris. And this is because of that in particular ICU, the patients coming and they are getting the infections from the environment as well. So it's like we see majority of the cases are in the immune compromised.
Yeah. Okay. I mean, and what about? I mean, as you mentioned a couple of times, antifungals in particular can be quite expensive. So, how is there ways of the government or other public bodies how they can help, sort of make these more affordable for and have this target and have it more targeted, have a more narrow spectrum. What we don't want to do is have it widespread and then cause more problems with resistance. So there's a very difficult balance, I would say, between between trying to make these things more available versus people using indiscriminate use.
Yeah, I totally agree. It's the challenge. It is a big challenge. I was like working with some of the teams like 2 years back. We were reviewing the essential medicine list. And what we have seen is there is no antifungal in that essential medicine list. Already know about the EML that it has to give the medicines at all the tertiary care hospitals by their own self. Like the government has to procure that essential medicine list. So that was a thing that we have already highlighted to the higher authorities that it should be there. But the thing is about the budget constraint and the financial constraint. The cost is high. Like I can give you example of caspofungin, which is available within the country. It is around 17,000 PKR, which makes around $60 US dollar per dose, and you have to give it in twice a day. So you can understand that it is costly, and if the government needs to procure and it has to give to all the hospitals, that they have to look at their financial commitments and their financial constraints as well. So one angle is there, but it is available in the market. The private sector and the other tertiary care patients can go and they can buy the antifungals at their own as well. The indiscriminate use, I'm for azoles and amphotericin, which is freely available, which is less costly. For these two drugs, we are worried. We see a high use of these type of antifungals, these two categories a lot, because they are less costly, they are easily available, and that can be the one good reason of the antifungal resistance burden that we have seen towards the azole within the country. Like for Candida auris, we always tell the patients that that empirical treatment should be the echinocandins. But due to non-availability, due to the high cost, the clinicians, they usually go towards the trial towards the amphotericin B. And after giving the amphotericin B or azole for a certain period of time, they see that it is not working. So they have to shift towards echinocandins. So this is the challenge that the patient is using. The antifungal patient is using treatment for some duration, but he or she is not seeing the response against it. And overall, the economy, the cost towards the health, the treatment has increased. So that is the reason behind it.
I have a question, a comment. I remember 2 years ago at the PACOB meeting. Now, the PACOB is a Presidential Advisory Committee on Antibiotic Resistance that was set up by President Obama of the United States of America. And they've been meeting every year, except they skipped a meeting during COVID. Anyway, so that was 2 years ago at the meeting. The representative of the Centers for Disease Control highlighted how Aspergillus fumigatus, right, a fungi you spoke about, was a bad, dangerous, opportunistic infection. And that in one study, one of the very rare study in the US done, they found that 30% of COVID-19 patients in that study had died from actually Aspergillus fumigatus. And he said, that person, that unfortunately there was only one laboratory in the entirety of the United States able to correctly identify Aspergillus fumigatus, while we had several in Europe. Could you comment on that? Because what he implied is that if there had been more studies on Aspergillus, we may have found out that it was actually a big killer in the COVID-19 pandemic, but it was not identified.
Yeah, I agree with you on this thing, that in all the during the time of COVID, we see high burden of these fungal pathogens, even not for Aspergillus, but mucor as well. You have heard about the black fungus, and many of the cases they are reported from the South Asian countries. So the burden was there because of the immune status has disturbed. So the fungi pathogen, they got the chance and they caused the infection. For the Aspergillus, in particular in Pakistan, I can give you example of the South Asian countries and other countries as well. The lab diagnosis that has been followed is the antigen antibody testing, particularly the galactomannan antigen test. The diagnosis to grow a mold within the laboratory, Aspergillus in particular, it needs a high expertise. And when we were doing the survey within the Pakistan, like back in 2017, 17 or 18, we have done our first survey to understand the fungal diagnostic capacity within the country. So we have sent a survey to almost 16 laboratories, and we have seen only 4 laboratories. They have the capacity to go for the culture, and to have some kind of biochemical test in form of Vitek, or some of the laboratories, one of the laboratories, they have the MALDI-TOF. So there you can see that across majority of the laboratories, we see only four laboratories, they have the capacity to go for the fungal diagnostics. So the reason is that the equipment is expensive. It needs more expertise. It needs high testing kits, high costly testing kits. So, and then a very expert human resource as well. So now, through our intervention, what we have seen that we are supporting 14 mycology laboratories, and there are many other laboratories which are well aware themselves, and they are trying to get the mechanism developed for the fungal infections to diagnose them. So you are right, the burden is there, but that if rightly diagnosed, rightly identified, we would be able to do it. Before this fungal culture thing, the most common test for the Aspergillus is the galactomannan indexing and the beta-D-glucane for the Aspergillus cell wall. So that was the thing that has been, these are the 2 tests which are usually prescribed by the pulmonologist because they see high burden of the Aspergillus within their cystic fibrosis patients. So this is the scenario. I agree with you that the disease is there, and because of the certain factors, we see that it is not picked up rightly. But through the interventions, through the awareness, we are trying to build up the system.
I have another question, and last question. You mentioned that Aspergillus is airborne. Is it mostly airborne, totally airborne? What's your views on that?
Yeah, it is. It is mostly airborne, and it is through the inhalation of the spores from the environment mainly. And yeah, it can cause many kind of allergic reactions and inflammatory reactions. Yeah.
Thank you very much. Before I pass on to Dr. Tousy for conclusion, I would like to invite you to do an entire webinar on this issue of fungal infection, because I think it's a very much a neglected issue internationally. I thank you very much for a very excellent presentation.
Thank you so much.
Thank you, Dr. Afrinish. I would echo Gareth's points on that. I think the thing is, actually, you'll agree, hopefully, the knowledge on fungal infections in general, isn't great among healthcare professionals. I think we lack that. I think maybe I would echo if we can maybe in the future, near future, organize something purely on fungal infections. I mean, I've learned a few things myself, and I'm sure my colleagues have, things like, the COVID-19 and fungal infection sort of link. So immunosuppression, I guess, from not only from antibiotics and other diseases, but simple viral diseases can then bring on a burden of fungal. So that can be a big challenge. And I think education on that would definitely be very useful. And that's been a positive from this webinar for sure. Just in conclusion, I think I want to overrun, and we thank everybody for their contribution, particularly Professor Yamagishi, on how to do investigations and surveillance, and his comments in the discussion, very useful discussion, and as well as then Dr. Afrinish and her sort of contribution, and obviously with the insights that Gareth provided with her sort of global view. So I think I would thank everybody for their contribution, and I think it shows that there's a big need for further webinars. I'm sure this webinar hasn't been perfect, but definitely it's a step in the right direction. And I think I would encourage us to develop this further and further. Thank you very much.